Good afternoon. I'd like to talk to you about Medicaid basics today, and this is in preparation for the policy development course. First, let's talk about why health is so much more important than other kinds of services. It's more universal. About 90% of all children have a preventive health care visit with a health provider, and it makes it the gateway for children's services. I'm going to talk largely today about basic facts regarding Medicaid. Medicaid is healthcare financing, and it works like insurance, but pays for many things most private insurance doesn't cover. It's also a federal-state partnership. Some rules set by the federal government, others set by the state, and they share the responsibility for financing the program. Part of the time today, we're also going to talk about the Children's Health Insurance Program, known as CHIP, which provides coverage to millions of children, originally authorized in 1997 and reauthorized and signed back into law by President Obama in 2009. It has been extended for eligibility through 2019, but funds only through October 1 of this year. So you may hear about this in policy discussions of this year. The CHIP program provides federal funds to states in a more like a block grant approach. It's not like Medicaid. It's not an entitlement to individuals. And states can also receive performance bonuses. Right now, 8 states have expanded CHIP as part of their Medicaid program, including New Hampshire and Vermont, which gives more comprehensive benefits to children. And you can see there that other states have combinations or separate programs that actually serve children through private plans. The key to understanding Medicaid is to understanding what I call the 3 E's. Is it an eligible service for an eligible child, covered by an eligible and enrolled provider? And that makes you understand whether or not it can be financed by Medicaid. So let's start with the first E, eligibility. Medicaid eligibility groups include pregnant women and children, people with disabilities, senior citizens, and those who receive cash assistance. The Medicaid expansions under the Affordable Care Act in about half of the states have led to inclusion of more low-income adults, up to effectively 138% of the federal poverty level, or just over $30,000 in annual income for a family of 4. By June 2014, under the Affordable Care Act, 66 million additional individuals were enrolled, and 66 million individuals were enrolled in Medicaid and CHIP. Approximately 7 million is increase over the prior year before the Affordable Care Act came into play, and the enrollment rose by about 20% over the baseline that we had seen. About 27 million children, or 55% of all children in the United States, are enrolled in Medicaid or CHIP. The enrollment rules matter, and they are set largely by states, but under the Affordable Care Act and other provisions, the federal government offers incentives for states that are doing things like enrollment based on the food stamp eligibility, or on parents' eligibility based on children's information, or 12-month continuous eligibility. And there have been new incentives for enrolling people, which is a reversal of past years when the states often tried to keep people out rather than enroll people in Medicaid. Children are more likely than adults to be eligible for Medicaid, and that's a deliberate action that occurred between 1984 and 1990 when Congress and the states approved a long series of Medicaid expansions, and then the Children's Health Insurance Program, and now the Affordable Care Act. But relatively few children were added by the Affordable Care Act. 90% of children were already eligible for public or private coverage before the Affordable Care Act. It mainly covered additional adults. Here you can see Medicaid and CHIP income eligibility limits for children in the 3 northern New England states, and that New Hampshire and Vermont have approved the Medicaid expansion, so their eligibility levels are high and over 300% for children. In Maine, they have varied levels. Infants are at a higher level and a higher level for their CHIP program, but no Medicaid expansion. I mentioned special rules for eligibility enrollment. Children are guaranteed coverage through the first year of life once they enroll, and pregnant women through pregnancy and 60 days postpartum. That's regardless of any fluctuations in income that may occur to them. optionally, states can extend 6 or 12 months continuous eligibility. The first two are required, and the continuous eligibility for children is an option. There's also something known as accelerated or presumptive eligibility, which allows a health center or a hospital to presume someone eligible and begin services while enrollment is being processed. The reauthorization of the CHIP program, known as CHIPRA, that act actually gave enrollment bonuses for states for doing a variety of the enrollment processes that I mentioned, such as continuous eligibility or presumptive eligibility, express lane eligibility. Let's talk next about Medicaid benefits. It has to be an eligible benefit in order to be financed. Some are federally required and others are optional for states to select. But for children, virtually any service covered under federal law, even if not covered for adults, would be covered. Medicaid also covers enabling services, coverage for medically necessary transportation or scheduling assistance, or informing parents about their eligibility and benefits. I'm not going to read this full list of benefits, but I want you to note that we are going to talk particularly about EPSDT services, but this is the standardized statutory list of Medicaid benefits in federal law. EPSDT is the Child Health Benefit Program in Medicaid. Virtually anything that's covered for children is covered as a result of the EPSDT benefit. So sometimes people call it an EPSDT program for children. To understand EPSDT, you follow the letters. It's early, starting before problems worsen, periodic, at regular intervals and as needed, screening, which is really comprehensive well-child exams, diagnosis, and treatment, those for medically diagnosed conditions. EPSDT screening visits are actually comprehensive well-child visits, and the guidelines for the schedule should be based on the American Academy of Pediatrics recommended schedule in Bright Futures. And these visits have 5 core components, which you can see here. EPSDT also offers a unique child benefit list with greater options for intervention and treatment, such as case management or speech language hearing or occupational therapy, for home visits or home visiting, for therapeutic child care, for mental health, for eyeglasses, hearing aids, and assistive technology, just to list a few. Medical necessity is a key term in relationship to EPSDT, and it means that the determination of whether or not a service is medically necessary must be made on a case-by-case basis, taking into account a particular child's needs if they're enrolled in Medicaid. Medically necessary is defined much broader in EPSDT and Medicaid than in most private insurance plans, and the purposes may be preventive, amelioration of a condition, curative, or restorative. Medicaid EPSDT services also can have a parent-child focus. They can support the family with information. They can offer health education and guidance to parents, deliver dyadic therapy to a parent-child. For example, infant mental health services. This is a common approach. They can give support to foster parents, or again, that scheduling and transportation assistance. Medicaid and EPSDT can meet a lot out of developmental needs, but the law does not list early intervention as a service category. At the same time, services under Part C early intervention may be covered, and other developmental services may be covered. Medicaid does not list child development as a service category, and at the same time, screening for developmental risk is required, and the assessment and diagnostic services as well as treatment services for child developmental problems would be covered. Developmental screening in EPSDT is important. It's one of the core components of those comprehensive visits, and it addresses the core domains of child development. As you see listed there, those are actually in regulation. Over the years, there have been no recommended tools, and there has been a lot of confusion about what's assessment and what's screening and what's diagnostic evaluation. That is changing, and a lot of advocacy has helped make those services more efficiently delivered to children. In summary, children have additional benefits under EPSDT that are not covered by adults. Not all adults get well child visits under Medicaid. The developmental screening and diagnostic assessments, dental care, therapies, rehabilitation, habilitation, and case management are just some examples. I've listed here just a few of the opportunities for states to maximize Medicaid, EPSDT, and CHIP benefits, giving parents more information about the coverage they might receive for treatment, recommending age-appropriate developmental tools and diagnostic screening, as well as developmental tools, separating billing between screening and diagnostic evaluation, or giving a bonus for screening delivered as part of well child visits, using age-appropriate diagnostic codes like the DC 0 to 3 codes, reimbursing for parent-child therapies, and covering services in a range of settings. There's nothing in Medicaid law that requires a service be delivered in a healthcare setting. If it met the 3 E's test, a service might be delivered in a child care setting or a school-based clinic or elsewhere. The second E is about eligible providers. Who are Medicaid providers? Well, they have to be enrolled and licensed to practice in a category that's identified by the state. And you can see here the list of those who typically qualify. Typically, it's not professionals with educational degrees, but a new provision actually gives greater breadth for coverage of community health workers under the supervision of other licensed professionals. Facilities may be considered the actual provider, and in those cases at the hospital it would be the physicians, nurses' aides, and others, all that billing into the hospital bill, or aides and therapists at a mental health center, or schools, counselors, therapists, and nurses. You can see that facilities being the provider gives a range of other providers to come in who might not be uniquely licensed in a state. Provider payment fees are set by the state, not by the federal government, and they can be fee-for-service arrangements, capitated or per member per month type arrangements under managed care, or global or bundled payments, for example, that's often used in maternity care to cover prenatal, labor, delivery, and postpartum care. So Medicaid financing is not too mysterious, but a lot of confusion exists for people about this. It is a federal-state partnership. There has to be federal and state money in it. The level of federal financial participation is set under federal law for each state, and sometimes it can vary by service. It is different for the medical assistance coverage and for administrative costs. States have to come up with what we call matching funds. In essence, they have to spend the money in order to draw down those federal dollars. And sometimes private or philanthropic funds can be used, but most of the money is public dollars, state and local. Medicaid interacts with the Individuals with Disabilities Education Act financing, and under a provision that I'm proud to say I helped to enact in 1988, the law says nothing prohibits or restricts use of Medicaid for Part C early intervention, and most states use Medicaid to finance early intervention, Part B preschool, and Part B school special education services. But that doesn't change, and the benefits and the 3 E's still apply. So there are things that are covered under individualized education plans or individual family services plans that would not be covered by Medicaid. And IDEA pays last after Medicaid. An emerging trend in Medicaid is related to measuring performance and quality. EPSDT is one of the few areas in Medicaid with national data reporting requirements, and throughout the history of the program, the so-called 416 data have been collected, but many people do not feel that's been a strong data for quality process. Medicaid and CHIP health programs are some of the first to have national quality measures. They are voluntary, and most states report on one or more measures. And states have other measures, such as using the HEDIS measures for managed care, or programs such as VCHIP in Vermont. I'm going to give you some examples of the data. Here's an example of the 416 data. So it collects about a dozen elements of information, and two important things that are calculated are the screening rate or screening ratio and the participation rate. The screening rate is an adjusted rate that takes into account how many months the child was enrolled in the program, the age of the child, and the expected number of visits for that age group. So you can see in the gray bars there the trend for Vermont among young children. In the red bar, you can see the participation rate, and that is what percentage of children had at least one visit in the year, not adjusted for their age or the expected visit. So, for example, we expect infants to have 6 to 7 visits, so it's highly likely that all of them got at least one visit. Another way that people use the 416 data is to show children the number of children who participate by age, and here you can see the Vermont data. The HEDIS measures have been set out about 20 years ago, and they are used by both commercial and Medicaid managed care plans, and the measures for commercial and private plans overlap a great deal. These are data from 2004, but these are still effective measures. One about did the child have 6 or more well-child visits in the first 15 months of life? What percentage of children in plans had it? So to read this chart, you can see in Medicaid the mean was 45%, and for commercial plans 68.7%. And then you can see the 10th percentile low performers, the 90th percentile high performers, and what's the gap? So in Medicaid alone, there's a 50-point difference between the low and the high performers, which means there's a lot of room for improvement among many plans. Another measure shown here is 1 or more well-child visits in the 3rd, 4th, 5th, and 6th years of life. And again, you can see a gap, although a somewhat smaller one. And you can see that for the infants, Medicaid is performing less well than it is for the older children in comparison to commercial plans. Here I've given you some examples of the Medicaid and CHIP quality measures. Again, these are voluntary. There are 26 measures last year, and I've given you some examples of the primary care measures. The two that we just looked at about well-child visits, there's one around access and adolescent visits, immunization status, chlamydia, and body mass index. Other examples not considered in the primary care set, there are 2 measures related to dental care, one related to developmental screening in the first 3 years of life, 2 measures related to asthma, and 1 related to follow-up care for children who are prescribed with ADHD medications. Again, just examples, and you have the links to learn more about that if you choose. But I think the real key information for some of us is here, that if there were 26 measures possible and states did this on a voluntary basis, North Carolina and South Carolina were the highest performers at using and reporting 25 out of 26 measures. In Massachusetts, 22 of 26. The median for the country was 16. Maine was reporting on 15, Vermont reporting on 10, and New Hampshire only reporting on 3. So there's certainly an opportunity there. In conclusion, I would just say things for you to take away: that all child and family advocates should understand the basics of Medicaid and CHIP, and that's particularly important because more than half of all children are covered in these programs. They receive their basic health coverage through Medicaid or CHIP, and many more receive partial coverage there. The Medicaid EPSDT benefit provides a gold standard coverage for pediatric care. It's based on the American Academy of Pediatrics Bright Futures guidelines for preventive services and has an individual medical necessity standard for treatment, which makes it very appropriate for children's very diverse needs, including those with disabilities. The CHIP programs that parallel Medicaid are stronger in their benefits and their cost-sharing requirements than those in private coverage plans. An array of providers participate in Medicaid, but more really should do so, and encouraging additional pediatric providers to participate in Medicaid is another advocacy opportunity. And finally, there are measurement opportunities, new ones for states, but states need to step up to the challenge of this. Thanks very much for listening today. You'll find more in your readings about this subject.